So obviously, it's going in between the legs. It's going to be, the CR is going to be perpendicular to the IR. Again, half an inch below the apex of the patella. Yeah.
My daughter's kindergarten teacher is chill out.
Uh-oh. Going up there later on.
We go.
You know, some of them teachers be mean and they be, them kids, you better believe
She
their
said,
children.
please make sure your child has 2 or 3 books in their backpack. They're too loud in the hallway in the
What?
mornings.
2 or 3 books.
Oh, they sent you that message just for you?
No, it was for the whole class. Yeah. Just to chill out. It's a kindergarten, of course they're gonna be loud. Expect.
Exactly. Go, you can go,
It's like telling them, you can stop buzzing.
I did it.
Where do you teach kindergarten for? I'm sorry, no, back to what, go ahead. I'm sorry, that's not on the test, by the way.
So obviously, we want the knee joints shown. So varus and valgus deformities. What's that, guys?
Varus goes towards the midline, and valgus goes lateral.
I think I'll finish each other sentences. That's
Alright.
teamwork.
I thought valgus was in. No? Valgus is not.
That's why you need to let us do that test.
Sure.
Valgus is lateral, so the L.
Oh, okay. Alright,
So it goes out.
Oh, so what you're saying is if you
The distal portion of the fragment is lateral or the distal portion.
It'll catch
How does
the
that feel for a weight?
curvatures.
wait, so like you're saying it doesn't necessarily have like a
I don't remember anymore.
combination like to open
Wait,
it
valgus
this
goes,
way
valgus
because
goes away?
some people's knee joint is way out.
It depends on the person. It's variable by the person, for sure.
Yeah, no, I had something written up here a while ago. It said, go away valgus or something like that.
is valgus toward or whatever?
This is
Oh,
Mm.
oh, I remember. I was like valgus, bust, goes away.
But if you think about this, this kind of looks like an R, right?
Yeah.
Let's move on, let's stay on track here.
Yeah. So again, always gotta have that collimation. Digital markers, not acceptable. Unacceptable.
Always?
Sometimes.
Why did you hesitate?
You, don't do that one.
I'm just like, I'll never accept it. Both knees without rotation, and one of the easiest ways, I know you can also look at the tibia and fibula, how superimposed they are or aren't, but I like to look at the patella. If it's in the center of the finger, that's how you know it's not rotated. Yeah.
This picture is not in the center, right?
No, it is.
Because we're doing bilateral.
Yeah, after this, we're gonna see some obliques, and then you'll see how the patella shifts, depending on which oblique you're doing. But this one, it's in the middle of the, like, it's like right here in the center of the finger. So that's how you know it's gonna be. And then you want this one's a little too low on the y-axis. It should be a little bit higher, so center's a little off, but it's still acceptable.
Let's remember his image critique class over here.
Oh, you guys are gonna be typing like this. Right. Oh, I should show them my PowerPoint later.
Yeah, we should.
Bony trabecular detail and soft tissue. You can see the soft tissue and then bony trabecular. It's not that great on here, but it's probably better on the screen.
Big smile if you take that picture.
No, I cut you.
What?
I'm just messing.
She collimated.
So here we have our AP oblique lateral rotation, right? So your AP, right? You're laying on the bed. So lateral up. So you're gonna make them go lateral. You're gonna push their knee outwards, right? You're going moving laterally. So if they need to, because some people aren't very mobile, they can like use their hips to push up, and then the unaffected side hip will be up, making their leg go out. The affected leg go out. So also like the AP, you want the knee extended as far as possible. And you want it a 45-degree oblique. And the way I like to visualize it is I put my hands on the condyles, and I kind of just like, I'm like starting here at 0, and then like when I think I'm 45, that's when I stop. And a lot of like you're gonna get a lot of people complaining when you're touching it. You're like and you're like, sir, I need you to move with me, just for a second, and then usually that works out.
And that's an important point to bring up as well, because some people, they're a little more flexible than others, it just depending on age. People can rotate their lower leg and not their upper leg. In some cases where you get an oblique in the tibia but not an oblique in the femur.
Yeah.
That sounds crazy, but that can happen. Or they might just oblique the foot, not the leg.
Yeah.
You want to, basically what I do is I put a hand on each side of the knee. I put a hand on the lower leg and the femur and say, I want you to roll with me. We're going to roll together slightly to this way. We're going to roll slightly this way. I need you to roll with me. Right. I need you to roll with me. I make sure that entire knee is rotating, not just one part of it. Make sense? So before he goes to the next slide, on a lateral oblique, where do you think the patella is going to be situated?
That's a good question.
On a lateral?
For a lateral rotation knee, where is the patella going to be
On
situated?
the
More towards the fibula, which is the lateral side, correct.
So what will be shown then if the patella is covering a lot of the side?
What's going to be the start of our show? Why would we do this oblique? What do you think we're going to be looking at? It is going to be a joint, correct. We'll find out in just a second. Stay tuned.
The fibula.
Okay,
But first, yes, we still have to do this,
the
guys.
caliper thing we were talking about the other day, or Mr. Donahue talked about the other day, and so,
Those numbers are hard to
Same
remember.
exact numbers.
yeah. But then, so, we usually go with the 5 degrees.
Yeah. You're almost always safe doing the 5 degree cephalic, but once again, for the board exam purposes, you would make these adjustments based on these measurements of the as is. We're measuring the as is, not the knee, the as is.
And again, below the apex, half an inch below the apex. So what I've noticed is whenever it's AP, it's always half an inch below the apex. And when it's like lateral, it's an inch below the condyles.
What? My phone.
You can take your time. I think this one comes up again.
It does.
We didn't get this one this year.
Yeah.
I didn't find out about it till capstone. I was like, what? You have to measure that?
I know. But the woes of bond trigger. I'm sorry.
You good? Alright.
There you go, guys.
Okay.
Was the bond trigger was like used, a lot, cause the tech I had, she said she's been doing this for 13 years and she still had the little, the bond trigger book.
Yeah, she should upgrade somewhere else.
Outdated.
Yeah.
Hey, it's still working for her. She's still in the game.
She's
13
still, yeah.
years.
I was gonna say,
I may
she's
think it's
getting
working
paid.
for her, but I guarantee those doctors aren't too happy about it.
She's still there.
How does it work, like, for example, for her that she's been doing it for so long? Like,
What's
how
up?
does she get updated? Like,
Most of the time they
I
don't.
should- I'm gonna go to the-
Don't be that way.
Char, are you good?
But how the lateral is one inch distal to the medial as it comes
do they
out.
send you links or stuff like that, or
I'm
you
sorry,
just have
what
to
you
just
said?
see it?
For the lateral knee, is one inch distal to the medial.
No.
You have to
It's
continue
still
education,
considered
yes,
AP,
but
right?
It's still AP.
Yeah, so it's an inch, it's half an inch below
stubborn
the
old
apex.
techs
Of the
are
patella.
very dogmatic.
And you can
that
get this
that
one.
is the way I've always done it, that was the way I'm always going to do it, I don't care. I've been doing this for 3,000 years, it's not gonna change.
Cause you know the apex is at the bottom,
Yeah.
and so it's half an
You
inch.
should not have that
You'll
mindset.
feel it, it's like
All of
squishy.
us in this
For the
room,
lateral knee.
no matter how old
It's
we
an inch
get,
below.
can learn something new every single day. We
Yes.
can always strive to learn something new every day. And I'll learn something
No,
new
you have no
positioning
patella.
with each edition of these books that come out. And I'm gonna embrace it because it's good to learn new things, because they optimize these positions as they make new additions. And I always wanna make those optimal image, because that's what the doctors expect, that's gonna make me look better than tech. So don't be one of those old fogies with the stubborn mindset that, just, oh, this is the way we've done it since the 1800s, so it still works, I'm not gonna change anything now.
Right again, we're doing this.
No, it's a bad mindset.
I learned this from Wilhelm himself.
Embrace open-mindedness. I think we're all very open-minded in this room. Embrace being open-minded. It don't pay off. It really does. Think outside the box. I'm gonna stop preaching. Go ahead.
So, as you see here,
In the book of Rinkin, 3:1, it says, "Thou shalt be open-minded in all radiologic Procedures. Thus saith the Lord. Okay.
Okay, so this is what's gonna be shown in your oblique knee. You have your femoral condyle, your patella right here, and you see how it used to be centered here in the middle, and you can even see the femur is kind of distorted, right? It's like it's bigger on this side than it is the other side. That's because of the oblique. Tibial condyles, right here. Tibial condyles. Fibular head, right there. Laterally rotated. So on the AP, remember, it was only slightly superimposed. Look at it now. Completely superimposed.
So, big star moment there, guys. Aside from the patella, because they might ask you what happens with the tib fib on the lateral rotation of the knee. Obviously, the patella shifts laterally, but what happens to the tib fib? They superimpose and that joint closes off.
Into half of the tibia.
They superimpose and the joint is closed. So, before we go to the medial oblique, what do you think is going to happen on the other one?
It's gonna be more.
It's going to be more separated. It's going to open up the joint further. So, if we're not looking at the patella, that's another way we can tell between the two rotations. The way the tib fib either superimposes or separates.
And the patella will be shot on the other side. I think there's one more there. So for your optimal image, you know, collimation, marker, not a great marker, use anatomical. So the medial femur and tibial condyles. So you see how like the patella is kind of over the lateral side, and this kind of like projecting more of the medial. So that's why this is, you do this, it's kind of weird, but you do the lateral one to see more of the medial side, because it projects it more, as you can see right here. Because the patella's covering the lateral, this one is more in profile, and so is the tibia condyle.
So like the lateral side is more foreshortened, right?
Yes.
So it's elongates.
Mm-hmm.
Basically, the medial condyles, femur and tibia become in profile.
Yeah.
They're put in profile.
It gets, oh, sorry. Okay, yes. It gets like this, and, well, this was never the way, but it gets like the patella out of the way, and like enlarges it, so you can see it better. Your tibial plateaus, right here you got the lateral and medial. So yeah, this is what I was saying. So it's in, so if it was over rotated, this fibula would be more in the center of the tibia. But so that's how you can kind of tell if you're over under, and because I've done one where I was over, and then this thing is like all over here. And then it takes like, do that again. I was like, okay, my bad. So it should be in like the first half of the tibia. Patella projected slightly beyond the edge of the lateral condyle. You see it barely coming off the lateral end of the femur. Open knee joint, it's pretty open. Is that closed? I'm pushing it.
It's starting to come closed, yes.
Okay. And then bony trabecular and soft tissue.
So let me ask you a fun question on the fingers. Let's say that was obviously an AP knee, in that the tib fib were more separated, everything looks AP, but the patella is still shifting towards the lateral side. What's going on there?
I think you said this last time.
Dislocation.
Yeah.
It would be dislocated. It'd be dislocated. So don't let that throw you off. You want to look at a combination of where's the patella as well as the tib fibs to determine that position. Because sometimes the patella becomes dislocated, it will naturally shift to the lateral medial side. So that can be our only indicator that we rely upon. Does that make sense?
So before I go on to the next one is medial rotation. How do you guys think the knee's gonna look for that?
The patella is gonna go towards the medial
Okay.
condyle, and then the fibula and the tibia is gonna be more
Separate?
Mm-hmm.
You are correct.
Pretty good, yes. Okay, so again, you can, for the same thing, so the other one, it was your certain AP, will come out. So you rotate the knee out like that, and if you gotta move your hips, you do. Same thing with this one. You put it, except it's going medial this time, and if you need to move their hips, move them. Knee extended as much as possible. Also 45 degrees medial, the other one was 45 lateral, so that's pretty nice that they're both 45. That's easy for you guys. Again, let's try again. this one.
Same exact concept still. There you go. See how it looks, guys?
Yeah.
Protruding on the medial side this time. And now you got this joint space open. You can see more of the lateral femoral condyle and then the tibial condyle.
Are you gonna, ask me an oblique?
Yes, I will. Yes, I will. You need to know how to identify those.
As long as you know where the fibula is.
Yeah.
Yeah. Well,
And if you see it open, you automatically know that's like the oblique.
You guys?
Wait.
Bro. My bad.
Okay.
I think you're gonna send this.
AP is
out
gonna be
to-
one.
No, we don't get nothing.
Like a little bit.
Yikes.
We just get the.
Yeah, yikes.
Which is the-
They'll thank me later. I know they're not thanking me now, but they'll thank me later.
You have it on
Sure.
video.
It's in your book. It's all straight from your book.
Yeah.
You technically have it all, guys.
Yeah, but it's better.
It is. Page
I feel like if I
355.
read it, I really don't understand it.
Cause they'll go back and forth,
like.
The red really helps.
Yeah.
Hey, at least I give you that, right?
We
It's
love
like some
it.
skeleton notes for you. I'm showing you what to focus on with the red.
Yeah, cause in the book is like, it has like a lot of information.
I put it in red for a reason.
It's like you sum up the information for it, and you highlight the most important. Yeah.
That's the aim.
So on this one, again, it literally shows the same things as the lateral, just different aspects. So again, the femoral condyles, you can see it right here. But again, this one's more in profile than the medial one. Your tibial condyles are also shown. And then, but the thing that changes is you're able to see this joint more open compared to the medial, lateral. And then, yeah.
Thus,
fibulous-
great test question opportunity there, guys. And always think, what kind of things did Mr. Donahue ask you on that position? What is the optimal knee view to best demonstrate proximal tibiofibular joints? This one right here, because it opens it up the most, as you can see.
All the other ones is closed. AP is closed, and then lateral is closed also. It's the only one that's open.
You said tibiofibular joint?
Proximal.
Proximal.
There's two, remember?
What's special
What
about the
knee
distal
view
one?
would open up the distal one the best? What knee view would open up the distal tibia joint the best?
Wouldn't it be the
Lateral?
medial?
Think critically for a second. What knee view would open the distal tib fib the most?
Medial. Oh, angle.
Wait, how
We
can-
are
how can knee-
further and further.
Knee.
He said knee plank does.
None of the above,
What?
because
It's
do we look at that
distal.
joint on the knee?
No. He said a
I said, what knee view,
projection is.
what knee view would open up the distal tib fib joint?
Oh,
A knee view.
Oblique.
See, it's verbal.
Exactly.
I had seen it.
If I-
Not the English.
Or if I said, which one would let you visualize it the best? Obviously,
all the way up.
none of the above. That's an example,
Cody, you
guys,
thinking critically. I like
of a
it.
critical thinking question. That's what the registry is failing people
Open it
on,
all
questions
the way
like that. We've got to learn to recognize little tricks like that, and we're going to. We're gonna get there. You're gonna be experts at this stuff by the end, guys. You'll be able to say, "Oh, that man, that ART super villain that wrote that question, he ain't gonna pull that shit over me. I got this. That's none of the above."
He said shade.
Shade.
Don't be scared. That's why we're training, guys. That's why we're brain training. We're gonna get there.
For the
Remember.
tibia,
Huh?
for the tib fib, we open up, we look at the ankle joint and the knee joint.
But he said a knee.
I said for a knee X-ray though. Not, we're not interested in the ankle.
If they-
It was the
just do
wording.
one picture,
It's the
you can
wording.
go.
It's
But
the
here-
wording.
but here-
Remember, a lot of times, guys, if it doesn't make sense, it's because it
I'm
doesn't
just
make
gonna
sense.
flag it.
You're gonna what?
Flag it.
Flag it.
And come back
to
later.
I don't find my
What about the ankle joint though? Which one would it be?
Huh?
The ankle view?
Which one for the ankle joint?
I mean,
Y'all
which
tell-
one for
well, y'all
the-
tell me, what's the ideal view to look at the entire ankle joint? including
Ortiz.
warranties.
Yeah.
Warranties.
But if you wanna see the distal.
If you just wanna see the distal a little bit better, which one would you opt for? Distal
Yeah,
tip joint.
Like the laterals or the
Distal
Yeah.
tip joint is only on the lateral side,
Yeah.
so.
It's the one Mr. Donahue
The
used to
45?
So you would need
The one I used to do, the 45-3 oblique,
Oh.
would open that one up the best, primarily.
If
What would
you
be all
really
that?
want it,
I see your
I
eyes.
think so, yeah.
We'll come
The
back to
horror.
this.
Because we only,
I don't know how I'm gonna do
we don't,
this.
we don't
You're gonna
do
do
this,
this.
like the
Don't
medial
set yourself
lateral is
out.
for the
Go ahead,
lateral.
Nick, keep going.
Like we don't do like that.
Okay, so
We do
your image
this.
criteria again, collimation, always.
Right?
Using digital marker, no bueno. Proximal tibia and fibula are separated. Yes, check. What you want to see. Posterior tibia. Wait. Oh yeah, this is what's in profile. Is your lateral tibial condyle. Lateral condyle is the femur and tibia. Again, this shows. That's what the medial one will give you more profile of the lateral sides. Both tibial plateaus. This one's kind of hard to see, in my opinion. The
The what?
plateaus.
I can still see them.
Yeah. So this one. This
Here
one.
and here.
Okay, so again, just how the other one, the patella protruded on the lateral side, this one's gonna be slightly over the medial side. Open knee joint. Looks kind of closed here, but it's pretty open. And then bony trabeculi and soft tissue.
Mr. Donahue,
Mhm.
how many hotspot questions do you think you could get from this image?
From this image,
A lot.
I can do probably all 20 on that one image if I want to.
Fever.
Oh, wait, you got a lot of stuff there.
Distal.
Distal what? You pointed at
There's
the,
more on
you pointed at the
fibula. Look,
plateau.
There's
Okay.
5 by the fibula alone. Apex, head, neck, fibula, joint. That's 5 right there.
How large would you have the apex?
How large do I have the apex? I'm still gonna make y'all the practice hotspot thing, by the way, by
Okay,
Friday.
thank you.
Just the point right here,
Okay.
the little triangular
So
point.
just not the actual tip
Head's
of
gonna be
it?
the rounded portion, neck is where it narrows.
What about the medial plateau
Medial plateau.
of the tibia? Would you just
Plateaus will
have
be
it that?
thin, guys.
Okay.
Plateaus will be thin.
That one was for you. That one was for you, so you don't put it on the edge. Put it in the center.
Yes.
What about the fossa?
The intercondylar fossa is those in between those little bony cheeks.
He said he was still asking.
Okay, so these are the ones I don't like. I'm not gonna lie.
Nobody likes these. But
These are, but
they're all.
I'm letting you
very
guys right
essential.
now, Mr. Donahue will ask questions about these.
Yes, I will.
We went over,
So
These are
just saying,
specialized
none of them.
views of the intercondylar fossa, which there are 3 main methods we're going to focus upon. All 3 of these achieve the same thing, by the way, opening
Yep.
up the intercondylar fossa. Excuse me.
Okay, so 3 of these are P-axial Holmblad method, P-axial Camp-Coventry method, and then apiaxial
Beclair.
Beclair.
Beclair, I say like a Frenchman.
Beclair method.
Beclair. That's the, wait, go ahead, that's the,
Oh.
the A sound on E's, the little accent. If it's that way it's F, if it's that way it's A.
Oh,
You want it French?
Okay.
Beclair.
Big Claire.
And you ever, have you
That's
ever went to
expensive.
Camp Coventry? It's a really great campsite. I always think of the campsite when I see Camp Coventry.
You must know the names as well, sir.
Yes, that's the method names.
Oh, it's gonna say them up here.
You don't want to show us? Huh? You want to show us?
Yeah. So you can with your knee, like I've never done this. I'm not gonna lie to you.
Of all the methods, this, in my opinion, guys, the Holmblad method is the best one for intercondylar fossa. In my opinion, that one works like, it's the easiest for the patient to do, and it just works great. That's the one if you're ever gonna do an intercondylar fossa, which they're super rare, we do them in pediatrics quite a bit, this is the one you wanna do, and usually I always want to do it just like this on the stool. Works great. Go ahead, Dave.
I have no experience with this. I'm not gonna lie to you guys, but The evaluate, you said you want to see the intercondylar fossa, so,
It's three ways there.
There's literally the 3 ways that are listed in order: standing with affected knee, flex on the resting stool, flex. And I'll give you the specific degree in the next slide. Standing beside table with affected knee, flex in contact with the IR. It's right here. Flex with the IR. Kneeling on table with affected knee over IR. Right there.
So main point on this one, guys, because you're gonna see a slight difference in how the leg is positioned. For Holmblad, no matter what of those 3 ways you're using, the main aspect is that the tib fib is flat on the IR while the femur is angled. So femur's angled, tib fib is flat. That's the main aspect of Holmblad.
And then I think the central ray is also perpendicular
It
to
is.
the IR. All these.
You said tip fib is flat.
Is everyone good on that, or?
Angle.
We're gonna talk about it more here.
Yeah. So, like Mr. Donahue just said, you see the tip fib flat right here. It's parallel with the IR, and then here it comes in at an angle. So, if this was fully extended, right? So let's say he's laying down prone or sheep, and then you increase it by 70 degrees your femur, and that's how you want it bend.
Basically, if the person's sitting on the table on their knees, like resting on their knees, as if you're like on the floor on your knees, your femur's gonna naturally basically go to that 70-degree angulation. So you're not having to like sit there and adjust them too much. They're gonna just naturally get on their knees in that position, which is why I like this one, because that's an easy one to direct somebody to do if you need to have it done.
Okay. So anterior surface of the knee on R, right here, anterior surface, apex of the patella center to the R. So, everyone knows the patella kneecap, so that's what you're gonna center to your IR. 7 degrees from full extension.
Do know that is a 70-degree knee flexion though,
Yes.
by the way.
It's not gonna be like just, it's like you're on the knees on your full floor. Perpendicular to the tib fib. So this is your tib fib, right? It's parallel with your R, so it's also gonna be perpendicular.
Popliteal surface or fossa.
So everybody knows what the popliteal is, right?
Behind the knee.
Behind the knee, so, popliteal fossa. How would you feel that?
Just the back of the knee.
The
Okay.
crease?
Just the crease, yeah.
Crease.
Okay, and anything at the level of the patellar apex, so.
So, not to be funny, but it is kind of funny. Your biggest enemy for this X-ray, what do you think it's going to be?
Your butt.
The butt, correct. The butt can get in the way. So you might need to make slight adjustments if the shadow of the butt is covering the image.
Yeah.
So it's like you might have to do slight little adjustments on it.
Would you have them like lean forward
Lean
a little
forward
more?
a little bit more, yeah.
Okay.
And that would be less than ideal, but of course, you wouldn't be able to see if the butt's in the way.
You gotta
The
work
tissue's
it
gonna
out.
cover up what you're trying to see.
You wouldn't have to move it out of the way.
No, I think you know the answer to that question.
Guess
Like,
it
lose your
takes-
license.
yeah, just tape your.
No, you're not gonna be taping any butts out of the way, you're just gonna. lean forward a little bit more.
I hope.
Okay, so
That's also why there's alternative methods to this as well.
Yes.
But look how pretty it looks. I love this X-ray. It looks so pretty.
So,
Huh?
right here you have, patella's pretty centered right here. You can see it's a good, it's not rotated. And also again, you can check the tip fib is slightly superimposed. So your start of the show is like Mr. Donahue said, the intercondylar fossa.
There's a clear difference, right? You can definitely see how lengthened the fossa is. So that's a clear indication that we're looking at an intercondylar fossa or tunnel view. I told you it's called tunnel views as well. So it looks like a subway tunnel kind of, or a train tunnel. So you'll notice as we go through these methods from Holmblad to come here to Beclair that they all look very similar. Thus, we wouldn't be able to deduce the method per se based on an X-ray, but we could if we looked at the position of the patient. Does that make sense? So I can determine the method by the positioning, but if I'm looking at just a plain X-ray, I would call it a tunnel view or intercondylar fossa view. I wouldn't know the exact method unless I viewed the positioning of the patient. Make sense?
So what this image gives you better than let's say the other knee projections is right here you can see the medial and lateral intercondylar tubercles right here. The eminence is in profile better. Also, the fossa and then the plateaus. So you're able to see the joint a lot better in this image. So this is your image criteria.
So let's make this simple, guys. You see a lot of evaluation criteria there, but I've only highlighted one part. What's the star of our show? It's kind of obvious. You're looking at a tunnel view based on that, right? Yes, this other stuff is going on, and it makes it more optimized, but focus on the star of your show for these. It doesn't need to be any more complicated than that because these are specialized views. They're not usually part of routines. They're ordered specifically by doctors. So literally, open intercondylar fossa is the main evaluation criteria for each of these.
Okay.
I do not like this one.
This is
It's the
the
reverse of what we just did.
So you saw how on the other one our tibia and fibula were parallel to the IR. On this one, the femur is parallel to the IR, and our tibia and fibula is the one we're angling. So here we have knee flex to 40 or 50. Oh, also the CR is also at an angle on this
We're
one.
gonna come back to that because that's a very easily confused part of these. I'm gonna come back to that in a second. Keep going. Okay.
So the knee should be flexed 40 to 50 degrees. Foot resting on support, you can see they got like a little box or something. I'm not sure what that is, but we have it resting.
Stonebridge or something.
Huh?
You like sponge?
Yeah, like a sponge.
Or someone usually just holds the leg, typically.
No rotation of leg. Center upper half to IR.
So before he moves on, so y'all see the clear difference between those first two methods. The first one, which is the home blad, the tib fib is flat and parallel while the femur is elevated. This one does the reverse. The femur is flat and parallel and the tib fib is elevated. But on this one, we have to actually angle our beam. Now we're utilizing a 40-degree angle on that too. It's time to think correctly for a second. Why is this actually a perpendicular central ray and not an angled exam?
Yes, they're also flexed.
And Cody is correct. Say a little louder.
They're also flexed 40 degrees.
Anytime, and we're gonna start seeing this more and more as we move to other chapters. This is a very important concept to grab right now, guys. If this part was not angled, if the leg was just flat and the beam was angled, we would be utilizing a 40-degree Claudette angle. But because our angle is matching the angle of the part, which is also 40 degrees, this is considered a perpendicular central ray. Does that make sense? If your beam matches the angulation of your parts, no matter what your angle is, like if I'm 30 degrees and the part's 30 degrees, that's still a perpendicular central ray. Does that make sense? It's a very important concept to remember moving on, because we're gonna see that more and more as we get to more advanced positioning.
Is that kind of like, so when I was doing portables yesterday, and we had, chest x-rays, and we would move up, the top half of their body, but whenever I would use the tube, it wasn't like, perfectly like straight, it was at an angle because they're technically not, sitting up like perfectly straight.
Right. Same concept.
Yeah.
So he's saying like if you're doing a chest x-ray on a patient and they're semi-upright, like they're laying like this with the bed at a tilt, and you match the tilt of their body, are we doing perpendicular or axial exam? Perpendicular because we're matching the angle of the body part. I used to do it all the time with babies because notoriously you go into the NICU to do a chest x-ray on a baby, they're usually tilted on their side or they're all cattywampus. There's your new vocabulary word for the day, look that up. It's a real word. They're cattywampus, so they're halfway obliqued. So what I would do, because guess what? In pediatric, in the PICU, you can't touch these babies or they'll go code red on you or code blue. They're that sensitive because they're premature. So I still gotta get a perfect chest x-ray even though the baby's oblique. So what would I do? I'm gonna match the angle of my tube with the angle of their chest. So I match the angulation, it comes out like a beautiful perfect AP. Is that an axial exam or perpendicular?
Perpendicular.
It's still perpendicular because I'm matching the angle of the body parts. Make sense? That can save you so many headaches, guys. If you can nail that concept right now, because guess what, trauma room, stuff's gonna come in very funky positions. This one I drew for you the other day, guys, with that foot that was up in the air. Remember the backwards foot I talked about? I matched my tube with the angle of the cassette. Was that axial or perpendicular? It's, well, for foot, it's using axial, but you get what I'm trying to say. You get what I'm trying to say. But the thing is, guys, if you can master that concept, that's what's gonna separate you from the, never mind, someone will say that a little nicer. That's what's gonna match you with the, I can't say it very nice. That's what's gonna make you a
Subpar.
super tech versus a subpar tech. Thank you, Jay. And it's also gonna give you just, you know, you can always, I always disagree with so many people like, oh, that's as good as I can get. That's the best I can do. What do I, is that my trigger sentence?
Yes.
Don't ever tell me that's as good as it can be or that's good enough. It's never good enough because it can always be better. And every one of us in this room can optimize films no matter how they come in, what position they are. We just gotta think beyond the normal a little bit. Critically think. And that's what makes you a super tech versus the one that's gonna be a vanilla tech in the next 50 years and never do anything with their life, which I don't want any of you to do to yourself because you're all better than that. So I'm gonna stop preaching and get off my soapbox, but go ahead, Nick.
So based off of what Mr. Donahue just said, so this is range of 40 to 50, right? So let's say we flex the knee 50. How would that affect our CR? They're ready for the test now.
Oh, no.
Wait.
Oh, sorry.
Oh, no, you change.
You're good?
I just said wait.
Oh,
for
for the
test.
test? Okay, so again, this is just showing that it's perpendicular to the long axis of the lower leg. So we're using it to match this part, the tibia fibula. Entering again, it's the same as the other one, popliteal surface, patellar apex again. And then like mentioned up, yeah.
So if we're matching it and it's perpendicular, so does that mean that basically that leg is just down?
That's what I was thinking too.
What was
Because if we're matching it, it means like, let's say they can't
But this-
put their leg down,
Yeah.
basically. And if we're matching it, doesn't mean their leg is just straight?
But if we were to make this straight, the femur would still be up. So it's like the same as
We're
the other
matching the
one.
angulation of the lower leg, not necessarily the fossa. Because the fossa is gonna be elongated, not the tib fib. So we're matched, because of our central ray placement, we are matching the long axis of the lower leg. But the fossa, the combination of the way the knee is bent and the central ray, that will naturally elongate it.
Structure shown.
It's the way that fossa sits in the body compared to the lower leg. Yeah,
So we're angling the two to match.
the lower leg angulation.
Okay, gotcha.
Therefore, it's a perpendicular central ray. Even though we have an angle on that too,
Right.
we're matching the angle of the lower leg, which is what we are lining our tube up with. So it's still considered a perpendicular central ray because it matches the area that we're x-raying,
Okay.
the body part. And even though it's perpendicular, because the way that fossa sits in the body, which you can kind of, it's not the best drawing, you can kind of see here, it's kind of slightly tilted. It's gonna elongate that fossa, which is the star of our show.
And then these last two bullet points is what we just talked about in the other one. It's like 40 degrees here, 40-degree angle of the central ray. And then if this was to be 50, then this would also be 50 to match the leg. Yes.
So essentially, Monty, to answer your question a little bit further, what would make this different from a regular AP knee is the way that the knee is flexed. So a regular AP, we have the leg straight out. If I was to sit on the table and put my knee at the angle that's similar to that, and shoot straight down, it's gonna start to elongate that fossa, which is why it's less than ideal to bend the knee for an AP knee. I want it nice and flat. As I bend my knee like so, I'm stretching the fossa open. It's basically I'm having the angulation and the distortions occurring from the way the knee is bent on this. Does it make a little more sense?
Yeah. Yes.
How do you know, like, what angle you have your leg at, like, so would
You learn to
like,
eyeball it.
Yeah.
turn?
You unfortunately learn to eyeball it.
So what I like to do is like, everyone knows what a 90-degree angle looks like,
Yeah,
right?
yeah.
So like 40, it's like half that. You get what I'm saying? It's just like, like Mr. Donahue says, you kind of eyeball it. But I always see 90, and I'm like, okay, like half. This looks about 40, 45. Shoot it. If it looks good, you did it
Would
right.
you angle your chin first and then be like, okay, I'm gonna do 40, like, and just go ahead and say
You
that?
could and try to match it.
Yeah, you could do that also,
Because
yeah.
I feel like if you try to angle your leg, I'm like, I don't know
But
if this looks more like 40.
I
If this is
they know it's the
also,
leg is
this is
better.
also why, because see how you're having to overthink this so much right now? That's why I prefer that first method. You don't have to worry about any of that. Just have them put their knee on a stool and point straight down. That's it. And you're gonna see in a second, guys, to show more what I'm talking about with the latest fossil and natural distortion in the knee. The Bayclair is gonna be basically the kind of knee we would do if the leg was bent up on the table in a supine position. So it'll kind of make a little more sense with the next method here.
Because honestly, this is like the exact same as the last one we just did. Just, this is parallel this time. That's why you got to.
Yeah, Johns?
When you talk about angling the leg, you see for this picture, the 40 degrees is towards the tibia and fibula, and the previous method, the 70 was on the femur. Like, how do you know which side to choose?
Oh, it's two different
Do you know which
examples.
method to use?
No, like the angulation, because for this one is 40 degrees, the tibia and
So the
fibula.
first one, there is no angle.
No, for the leg.
No, the 70 degree. You know, it's kind of like you're bending down.
Oh, because, well, that's something you learn to eyeball as well. That's why I told you naturally, typically when you get on your knees, like if I was on my knees on the floor, supported with my hands, the femur basically naturally goes in that 70-degree angle. Otherwise, you just kind of eyeball and shift them around a little bit.
So for the previous one, we're angling the femur, and for this one, we're
Yeah.
angling the tibia and fibula.
Yeah.
What are they looking for when they're doing like? What kind of pathology are they looking for if they do this?
If there's any fractures in the interior of the fossa,
Okay.
or maybe there's a cancer in there, some kind of bone lesions as well is another thing. It just depends. It's also why they do it on kids a lot, because a lot of kids get little bone lesions from abuse cases as well.
Mhm.
And you can open up that fossa, that tunnel view, to get a better look inside the interior, see if there's anything fishy going on in there.
Okay. Does this look familiar, guys? Almost looks like the last one we just looked at.
Yep.
So you're seeing the same things as the other one. I don't think this view gives you anything else that the other one does, right?
No, they're basically 3 ways of doing the same exact thing that we're looking at here.
So
Why does the outsides of the femur look
it's like dark.
yeah?
Bad technique.
Yeah. Because it is.
Or someone using photo time when they shouldn't be.
Alright. So
AEC.
this is
Y'all
a-
never use AEC, right? You know, we got quiet on that.
I just do it with a text.
I was like, what is that? What is that?
He's like that.
And that's what they told you to do.
Exactly.
Come back.
Yeah, this is similar
What
to
is
the
that?
other one. What's the pasta again? Intercontinental pasta.
I hate AEC. That's a pretty one there.
Yeah, this was better.
Lots of bunch
So
Once again, guys, you see that one red line there? What's our main aim of the game here? To open that intercondylar fossa.
And the fibula is more in on this one too.
The what?
The fibula is look like
well, look
it's-
at the kneecap too. It's a little.
Yeah.
It's a little rotated.
Oh,
Yeah, that's
it's
good.
supposed to be.
Just slight. It's just slight though.
That's where we'll stop today, guys, because it is 1 minute to 10 o'clock. So we actually just have a few slides left, guys. We're just going to talk about the Bayclair view and a few patella views, and then we'll wrap this chapter up and we'll review on Friday. Any questions? All right. Well, go ahead and take a little break, guys, and we're going to do our practice registry exam next.
Oh.
Man. Thank you.
Don't everyone go at once.
I want to look at it more. Are you good?
I know.
11.
Emily, I'm just going to leave you logged in since I'm doing the next class as well.